Next, we move to Professor Ang Leong. Professor Ang is a senior consultant and professor of medicine and also a head research at Yankee General Hospital. Professor Ang also have international publications, more than 240. This time, Professor Ang will talk about the update in endoscopy in 2024. Professor Ang, please.
Hi, good morning, Chairman, ladies and gentlemen. It's a great pleasure and honor for me to be here in this very important meeting. I'd like to thank Professor Varachai and Professor Alcon for their very kind invitation. So I've been asked to talk about update in GI endoscopy, and I must echo what Francis said earlier. It's a huge task because so many important papers have been published the last 1 year, and there has to be some element of subjectivity. So I've actually looked at what was published the last 1 year plus in GI endoscopy, and also some other journals. And I think these are important topics that we should be aware of. So I'm going to focus on the following 4 areas. One will be AI and image-enhanced endoscopy. I'll talk about endoscopic resection, some discussion on EUS and ERCP, because these are topics close to my heart. And also, last but not least, the topic of green endoscopy. I think foremost of all, let's talk about AI and image-enhanced endoscopy. I think this paper was published recently. It is about post-colonoscopy CRC in the program that's accredited to conduct colonoscopy for CRC screening. So we are reminded that even in a highly accredited program that look at high quality colonoscopy, colon cancer can still be missed. And this is an important issue because interval CRC usually have poorer prognosis because they may be at a more advanced stage of disease. Currently, we do have several tools to help us see better and potentially detect better. And these tools can be roughly categorized into 2 types. One would be to highlight subtle changes in the exposed mucosa, such as image-enhanced endoscopy, and also artificial intelligence. And the other set of tools help us to expose lesions that are covered behind mucosal folds. So these are the distal attachments, such as a transparent cap or the endocuff vision. So just to summarize very quickly, what does IEE does? In essence, it helps us to see mucosal surface better. And in the not too distant past, we had technologies such as narrowband imaging, blue light imaging, or OE from the different company. And in more recent years, we have newer technologies such as link color imaging and also TXI from Fujifilm and Olympus respectively. So this technology actually uses white light as a base, and it processes the image such that any focal lesion will be made more prominent, maybe a bit more pink or red, and the background mucosa become a bit more pale. So this enables us to see any focal lesion a bit more clearly. These 2 papers were published last year and this year. It looked at the impact of link color imaging on ADR and also SSL detection. So this was a large multi-center randomized controlled trial conducted in the Asian Pacific region. I think there were centers from Thailand, Singapore, and it was headed by PI Professor Suzuki from Japan. So it shows us clearly that link color imaging can help us improve the adenoma detection rate, and it can also improve the detection rate of SSL, which we know is also very important because it follows a different biological pathway for colon cancer carcinogenesis. Post-hoc analysis look at the impact of LCI on SSL detection, and it shows that factors such as longer examination time, experienced endoscopies, link color imaging, all help to improve the detection of SSL. If we change tech and look at another similar technology, which is newer, TXI, this RCT published just this year shows us that TXI, when compared to white light endoscopy, does improve the detection of adenomas. And again, that's because makes the lesion more obvious, and therefore it helps us to see better, and it can improve the detection rate. You remember my earlier slide, endocarf and TXI or LCR are actually trying to help us see better using two approaches. So one is trying to make the subtle lesion more obvious, and the other is to expose more of the mucosa so we can have a broader field of examination. And therefore, as expected, when we combine TXI and endocarf, it does help to improve the detection rate when compared to TXI alone. Now, let's move to AI. I think AI has caught us by storm, and I think many places are using AI routinely. Certainly, there's some concern about whether we are detecting more things and whether it actually make us do more resection, which is unnecessary. But nonetheless, I think it's quite clear that AI improves ADR. And we do know from past studies that increasing ADR helps to reduce the incidence of CRC-related incidents and also mortality. And there are so many systems in the market right now, and more are being undergoing regulatory approval. And this meta-analysis shows us clearly that probably all the systems are somewhat similar in helping us to see better and detect better. I used to think that if you're very experienced, probably you do not need all this help, because you can see you have a very careful examination technique. But again, this MA shows us clearly that regardless of your level of experience, whether you're a novice or a highly experienced endoscopist, when you use tools such as AI, you can see better and detect more and improve your ADR. And I guess no matter how experienced a person is, there are times where our attention wanes, and when we sort of take our eye off the monitor, and AI, by helping us put a box there or creating a beeping sound, help us to focus our attention to detection, and therefore help us to see better and detect more adenoma. And again, when we combine AI, which help to us to detect subtle lesions more, with endocarf, which help to flatten the fold, it's quite clear that when we combine such technology, we can actually see better and improve our detection rate. So certainly, not all centers have all this technology, but if we do have it, do consider using all this technology, especially in the high-risk population, especially such as those with FIT positive undergoing colon cancer screening. So naturally, once you have detected the lesions, we move on to resection because we want to prevent disease progression. So therefore, I'll talk a little bit about endoscopic resection right now. I think currently, endoscopic submucosal dissection is getting more and more popular, and more people are trying to perform that to treat both early cancer as well as large lateral spreading tumor, which is just dysplastic. But we all know that ESD is a bit technically challenging. Not everyone is able to do it well, and we have such a large patient population that require intervention. So there were two recent studies that look at endoscopic mucosal resection for large, flat, non-pedunculated colorectal polyps. One study was RCT from Australia, and another one was RCT from Germany. And both look at large lesions, more than 15 to 20 millimeter, and they wanted to compare cold snare resection against hot snare EMR. So you realize that cold snare was sort of the rage a couple of years ago, and a lot of people are using it for diminutive lesions less than 1 centimeter because it's been shown clearly to improve en bloc resection rate compared to piecemeal biopsy using the cold forceps. So these two studies try to look at whether we can expand the use of cold snare EMR to larger lesions, and the value proposition was that when we use cold snare, there's less thermal injury, and therefore it can potentially decrease the risk of delayed complications such as post-polypectomy syndrome, delayed bleeding, delayed perforation. And because of the technique, inevitably we have to do piecemeal EMR. And these two studies show us clearly that, well, in terms of technical success rate, both hot snare EMR and cold snare EMR can achieve similar technical success rate. and potentially cold snare may reduce adverse event rate. But the downside is that when you do cold snare piecemeal EMR, the local recurrence rate is actually much higher. And this raises the issue of whether we should actually do it. But I suppose these studies also show us that, well, it's something that can potentially embark upon if we come across the correct patient population, especially for those where we want to really minimize the risk of post-resection delayed adverse events. Related to this topic of local recurrence, right now in the past, what we do after we have done piecemeal resection is examine the resection base carefully using our eyes to see whether there's any gross remnants. And if there isn't any, we're happy, then we will arrange a short-term surveillance colonoscopy. So this RCT actually compared using the tip of the snare to routinely ablate all the resection margin versus the use of argon plasma coagulation to, again, in a systematic manner, ablate all the resection margin. And the third arm, which was a control, was just based on our visual estimation, no further treatment to see what is the actual outcome in terms of local recurrence. So it's quite clear that both APC and soft tip, snare tip soft coagulation help to reduce local recurrence rate compared to no further ablation. And interestingly, the snare tip coagulation works better than the APC. And I think this is important because when we do the resection, we're already using a snare. So we are just using the same snare, the tip of the snare to ablate the margin. And therefore, it can actually potentially save costs for patient while further increasing the therapeutic success rate. A bit more on endoscopy resection. I think whether or not we do EMR or ESD, we are bound by a so-called set of histological criteria that defines cure. In the case of colorectal dysplasia or early cancer, I think it has been defined that so long as the vertical margin is not deeper than 1,000 micrometer, there's no lymphovascular innervation, there's no advanced tumor budding, it is considered a curative resection, and therefore patient need not be subjected to salvage surgery because the risk of lymph node metastasis is very, very low, very, very minimal. So this meta-analysis was published 2 years ago, suggested that perhaps the vertical margin by itself, i.e. if it's more than 1,000 micrometer, need not necessarily be a definite contraindication, a definite factor that requires a salvage surgery. Because in all the previous published studies, there are probably many confounders like whether or not there's concomitant lymphovascular invasion, whether there's extensive tumor budding. So therefore, it is actually not so clear. And we probably want to discuss further with patients whether or not they really want to undergo a salvage colectomy with lymph node dissection especially if they're older age with higher risk of post-surgical morbidity and mortality. And related to this, this year, this longitudinal study examined patients at high risk of local recurrence. So these are the high-risk T1 CRC who underwent resection. High risk meaning to say the vertical margin was more than 1,000 and they included high-grade budding, poor tumor differentiation, and or concomitant lymphovascular invasion. And this study compared a control group who underwent surgery, and it shows that in a selected patient population, even if they don't undergo salvage surgery, their long-term outcome was similar to those who underwent salvage surgery. So again, this highlights that we actually need to individualize our treatment approach to patients who meet borderline curative criteria because we don't want to subject patients with poor morbidity to an unnecessary surgery. Let us now switch focus to endoscopic ultrasound and ERCP. There were many studies to look at, but I thought I want to look at something more general and then also in the area of interventional EUS. So I think in the past, guidelines suggested that we may not need to routinely provide prophylactic antibiotics for patients undergoing ERCP if they don't have an active infection, and we are quite confident of achieving good biliary drainage. But there's always this concern, because once we cannulate a sterile field, which is a bile duct, we inject contrast, there's always a risk that we can trigger transient bacteremia. So this RCT conducted from Korea looked at the use of prophylactic second-generation cephalosporin routinely given before ERCP procedure. And it shows us that actually, when we do it routinely, we can reduce the risk of infection. And therefore, this suggests that we may want to reconsider our practice and give routine antibiotics before therapeutic ERCP. What we are giving is a short-term prophylactic course, so that should not lead to a higher risk of antibiotic resistance. In addition, pancreatitis is another important concern when we do ERCP, and you all remember the ASG guideline published a few years ago about the different options which were substantiated by RCT, MA, about how rectal NSAIDs, the use of PD stenting, high intravenous hydration can help reduce the risk of post-ERCP pancreatitis. An important question was, for high-risk patients, do we need to give both rectal NSAIDs and also insert the pancreatic duct stent to reduce the risk of post-ERCP pancreatitis? Because it is actually very attractive to just give rectal NSAIDs and not do PD stenting, because then we don't have to repeat the endoscopic procedure to remove the stent. So in this RCT, it actually compared in a high-risk population at developing post-ERCP pancreatitis, it compared giving rectal NSAIDs alone against giving rectal NSAIDs plus insertion of PD stent to see whether there's any difference. The study design was a non-inferiority design, whereby if the risk of post-ERCP pancreatitis does not exceed 5%, then it is considered that there's no difference between the two arms. Unfortunately, this RCT the risk actually exceeded 5%, so it was more than 6%. So it actually shows us that perhaps in high-risk patients, such as those who undergo a pre-cut after a traumatic attempt at cannulation, those with undergoing endoscopic papillectomy, in addition to giving rectal NSAIDs before the procedure, we should actually also routinely insert the pancreatic duct stent to improve the pancreatic drainage and reduce the chance of post-ERCP pancreatitis. Routinely, we have been asked to perform ERCP and drainage of patients with pancreatic cancer who are actually suitable candidates for surgery, but for some reason are unable to undergo immediate surgery. And a lot of time we have been asked to insert the plastic stent because there's this concern about metal stent interfering with the ease of surgery and also being more costly for patients. I suppose if we were to organize a surgery quite soon, within 1 or 2 weeks, it probably doesn't make a difference. This meta-analysis shows us that, well, for patients who undergo biliary decompression before surgery, especially if the time to surgery is a bit longer, if we were to insert a self-expandable metallic stent, it actually helped to prolong stent patency and reduce the chance of infection before the arranged surgery date. And therefore, it actually helped to improve patient outcome. Now I move on to the issue of EUS. I think increasingly we are all doing more EUS-guided biopsy rather than EUS FNA. And that's because it can give us more tissue, potentially increase our diagnostic yield, and allow molecular diagnostic. So these two studies show us clearly that when we do EUS FNB, we can reduce our number of puncture to 2 or 3, as opposed to the 4 or more when we use the FNA needle. And importantly, by giving us a core tissue, we can then use the material to do molecular diagnostics, use it to create organoids to help us in personalized treatment for patients with cancer. And I also like to briefly discuss the role of interventional EUS. I think a lot of time we are actually using EUS-guided drainage for ward-off necrosis, because it's actually less morbid than surgery. In the past, we've been using plastic stents, but in recent years, self-expandable metallic stent that are lumen opposing were available. So this MA shows us clearly that, well, apart from shortening the duration of procedure to just a few minutes, as opposed to maybe 10 or more minutes, it probably doesn't make any difference in terms of efficacy, but it does reduce the cost of treatment. US-guided biliary drainage is another hot topic, and especially in the case of whether or not we should even attempt ERCP in the first place rather than reserve it as a second-line procedure. So this MA shows that if we were to embark on US-guided biliary drainage compared to ERCP, the efficacy is probably the same, but it can potentially reduce the risk of adverse events such as pancreatitis, and also help us achieve a longer patency because there's no risk of tumor ingrowth. I'll be coming to the last part of my talk because I understand that time is running short. So I'd like to end up by talking about Grande endoscopy. I think we are quite aware of the impact of global warming and the impact of global warming on health, and how us as healthcare providers, the healthcare sector does contribute to greenhouse gas emission and therefore contribute to the problem of global warming. And recently, 2 surveys were published. One was from Asia Pacific region, and another was from Europe. And it does highlight that there's growing awareness of this topic and the fact that what are the potential steps you can do to help to mitigate against this problem. And I think it's quite important that when we want to be mindful about sustainability, carbon costs, we try to decrease the rates of unnecessary endoscopy because every procedure carries with it a certain carbon burden. And this study from Italy shows clearly that if we were to do unnecessary upper and lower endoscopy, it does contribute significantly to the greenhouse gas emission and potentially to global warming. But being aware of sustainability, being aware of green practices doesn't mean that we need to regress to the Stone Age and stop doing endoscopy, because as healthcare providers, we need to maximize whatever is available to get the best benefit for our patients. So this study shows that, well, perhaps we can continue doing screening colonoscopy because screening colonoscopy does help to pick up lesions at an earlier stage, and when we pick up things at an earlier stage, the resource needed for curative treatment is actually lower, and therefore, even if we were to do more appropriate colonoscopy, we actually help to reduce the downstream impact on carbon burden and help to drive a more sustainable practice. So with this, I thank you for your attention. Thank you very much.